are dropping dramatically. The Beck Hopelessness Scale is the most powerful predictor of eventual completed suicide in the mental health field. And we're dropping that score by pushing 50% just in 19 days. The dissociation scale score doesn't drop because treating dissociation takes longer. So we're focused on the hopelessness, the depression, and the suicide. Those are the main things that we want to address in patient. And what we see is at 3 months, these gains are sustained, so they don't just like relapse next week. And now the dissociation scores are starting to come down. And at 2 years, we're seeing, on the average, these scores dropping into the normal range. So now like the dissociation score is like 12, the Beck depression score is like 6 for the average person. Phenomenal, dramatic, sustained improvements in depression, psychosis, substance abuse, eating disorder symptoms, dissociative symptoms in people who are carrying on with their trauma recovery work as outpatients. So there's actually a series of published papers. So you have the handout here. This is just a list of the references. And I could talk about the methodology and all kinds of stuff, but nobody else has data superior to this for actual real-world inpatients for any treatment of any kind, for any diagnosis of any kind. Because most of the studies are done on these kind of outpatient, very carefully selected, milder cases. And the 2 books that I recommend if you're going to buy a book of mine, Trauma Model Therapy. The Trauma Model is the first one, and it's kind of the scientific model of how all this works scientifically, and a bunch of research predictions, and then a bunch on the therapy. The Trauma Model Therapy book is the #1 recommendation. It explains the model, which I'm going to jump into now, and it's got a lot of detail on this strategy, this strategy, this strategy, this technique, this technique, this technique, and it's got conversations, therapist-client, illustrating the treatment strategies. So it's very hands-on, practical kind of book. And the author is like this very learned guy.
I just have a quick question.
Yes.
I just wonder how this may differ. I was very influenced early on in treating dissociative DID by your book, Dissociative Identity Disorder, and I just wonder if you'd address how your thoughts and treatment differs from that.
Very good question. How does this relate to my dissociative identity disorder book? I've learned kind of everything about everything from working with people with DID. And so what I've done is, just like I said in the dissociative structural model, this is DID kind of scaled down to about halfway and applied to many, many, many different problems in the mental health field. So it's the same basic core problems, same strategies, same treatment goals. When you're scaling down, though, you may not have some of the DID specific stuff, but mostly it's the same. So it's kind of DID therapy adapted to a bunch of stuff, basically. So now, and this will spill over into the afternoon a little bit, we're into, okay, how do I actually do the therapy? And the trauma model therapy's got these main components that I'm going to run through now. The 2 core ones are the problem of attachment of the perpetrator and the locus of control shift. And then those other ones are important, use them all the time, but not quite at the core of the model. So this picture, so I'm going to do problem of attachment to the perpetrator now. This is a little hippo that was a victim of the tsunami, that lived on the east coast of Africa somewhere, was washed way the heck up and got separated from its family and ended up next door to this giant sea tortoise, and they became best buds and formed a bond. Aww. So how touching is that? I mean, look at that little guy leaning into his foster mom, basically. So this illustrates the core idea in this treatment model. And this model actually is not that useful because it doesn't apply to insects, reptiles, or amphibians. It's only good for birds and animals. But if you happen to be treating mammals, the model applies. So if you're a little grasshopper or a little salamander, you don't go to the Hallmark store to buy Mother's Day cards because you don't have any money, you don't speak English, and you don't have a relationship with your mother. And sometimes you've got to take off into the jungle or the swamp pretty quick because mom might eat you. So birds and mammals are different. Birds and mammals are completely dependent for their biological survival on an adult caretaker for a period of time after birth, which could be weeks or months in some species, and human beings tends to average around 35 years or so. So you got this little being who's completely dependent for biological survival on an adult caretaker, which often is biological mom and dad, but doesn't have to be. So you're genetically programmed to bond to, attach to, connect with, love, and need to be loved by an adult caretaker. It's not about race, gender, culture, IQ, it's about being a mammal. And it's not an option, and it applies to everybody, including hippos. So, in the normal course of events, this kind of works out okay. Mom and dad are present, consistent, loving, kind, lots of unconditional love, consistent parenting and nurturing, a few little bumps in the road. And what do you learn? The world's a safe place, I'm a good person, I have basic trust, I don't have a ton of mental health problems, it all works out okay. But the people who come to the trauma programs, or the jail, or the battered spouse shelter, or the residential treatment center, or the homeless shelter, by and large did not have an okay childhood. By and large had this whole melting pot of physical abuse, sexual abuse, family violence, chaos, impossible double binds, absent caretakers from death, divorce, imprisonment, substance abuse, mental health, family violence, inside the home violence, outside the home. You could throw in some surgical and medical trauma. And so far I've only been talking about North America. If we go elsewhere in the world, sexual abuse inside the family is going to be swamped out by the fact that 40% of adults in the country are HIV positive. Chronic disease, tsunamis, famine, disaster, wars. So if you look at the burden of chronic, severe, complex childhood trauma on the planet, intrafamilial domestic violence and sexual abuse are fairly modest slice of the pie. But here in North America, they're a big slice of the pie. So we're a little bit over-focused on physical abuse, sexual abuse, just because we have a little bit better public health and a little bit less warfare going on than other parts of the world. Okay, I can't resist a political comment. So, if we were actually in fact concerned about civilian body count on mainland US soil, and that was our primary priority, that we wanted to reduce the body count over the next 10 years, we would have to make a threat assessment for the past 10 years. We would have to count up the number of bodies on US soil from terrorism, which would be whatever, 3,500, whatever the number is from 9/11. That would be the body count, which would establish the priority level of that threat, which would then establish the priority level of our threat response. Then we would have to compare that to other causes of death. Childhood physical abuse, childhood sexual abuse, and family violence would add up to at least 10 times that much. So if we were actually hard-nosed, no feelings around here, just caring about the body count, and we wanted to maximize our efforts to reduce the civilian body count on US soil, we would spend more on childhood abuse and domestic violence than we do on the war on terror. Confident that you wouldn't disagree with me. The defense contractors are not in favor of focusing on the war on domestic violence and child abuse. So, back to the problem of attachment to the perpetrator. So people come into the program and they haven't had consistent nurturing and parenting. What they've had is this huge melting pot of family violence, physical abuse, sexual abuse, neglect. Sometimes dad's there, sometimes he's great, sometimes he's gone, sometimes he's great, sometimes he's horrible. And so this little mammal's been trying to bond, connect, form an attachment to a person or two people who are also the primary perpetrators. So the people for whom you're biologically dependent on your survival are also the people who might kill you. More children get killed by their parents than by anybody else. The dirty old man down the street is not the primary threat. Neither is the Middle Eastern terrorist. The primary threat is mom and dad. So, what happens when there's big trauma, abuse, scary behavior, violence? Another built-in genetic, basic mammalian threat response system kicks in. You can't beat your parents up. You've got to go into shutdown, flight, I'm out of there, I can't take it anymore, disconnect, detach, which would be a great solution. You could just curl up into a little ball, become completely catatonic, and nobody could get through to you or hurt you again. Then you would look like the child who came out of the Romanian orphanage, who got enough protein, got enough carbohydrates, got the diaper changed, but didn't get the nurturing, didn't get the love, was just baby 37 and crib 37. And those kids come out profoundly developmentally impaired, emotionally, spiritually, interpersonally, in all possible ways you can imagine. And there's actually a thing I learned about in medical school called pediatric failure to thrive, coming from neglect, where you're actually physically, measurably stunted in your development. So it's developmental suicide to go into shutdown mode. Everything to be okay, so that mom and dad are consistent, safe attachment figures, you've got to put the bad stuff over there somewhere. You cannot see the whole picture. You cannot have an integrated cognitive map, emotional map. You can't have an integrated set of behaviors because your parents don't have integrated behaviors towards you. They're in the abuse channel or the absent channel or the nurturing channel, on, off, up, down in this inescapable, crazy, inconsistent, chaotic pattern. So you develop two disconnected modes inside. I'm okay, you're okay mode, everything's all right. And then, whoa, everything's horrible, I'm out of here, I'm shutting down. Can't stay there, I've got to get back into attachment mode. This is called borderline personality disorder. This is the borderline dance. This is the I hate you, don't leave me. Having this borderline personality structure is, to my mind, the logical, predictable, inescapable outcome of being a mammal who's trying to form an attachment to perpetrators. There's no other way to be, whether you meet the actual DSM criteria or not. So here I brought along a couple of MRIs for you here. This is the MRI of somebody who comes into the program and they're like a really severe borderline personality disorder person. Well, the intake procedures sucked. The nurses are horrible here. I can't stand the food. I can't believe that the bed is this and this. And I might as well just kill myself right now. What a waste of time coming here. And by the way, Dr. Ross, I haven't talked to my parents for the last 100 years. They're both idiots, and I'm done with them. Dr. Ross is going, ooh. Well, at least I'm glad to hear you resolved your problems with your parents. So this person is in, I'm out of there, I hate you, I don't need you for nothing mode. Okay, everything's so horrible, why are you here? Oh, you're not going to stay. You're going to discharge and kill yourself. Okay, I get it. So this person is obviously in the negative side of the borderline dance. Doesn't need anybody for nothing, done with all of that. What do I think happens when this woman's drifting off to sleep at night? I think a tear rolls down her cheek, and she says to herself what she can't allow to be true during the day. If only Daddy would come back, say he was sorry, make it up to me, then I'd have the daddy that I always wanted, and everything would be okay. So she's hiding in the negative to avoid the pain of the positive. But who wants to stay in the negative? So you got to get back to the positive Well, you can do that with wild sex, drugs, alcohol, cutting, for a little while. Then you fall back into the negative. Then you got to act out some more, or you got to have another pathological dependent relationship, and everything's great till he beats you up, and then you're in the negative. This sounds kind of like life at the battered spouse shelter. So at the battered spouse shelter, there's no DSM, there's no psychiatrist, there's no diagnoses, nobody's saying the word borderline, but it's the borderline dance to the max. The woman comes in, I'm out of there, he's a perp, I'm not taking any more, I don't deserve it, I'm done with that. Little round of applause, thumbs up, a couple of politically correct affirmations, problem solved. A week later, oh wait a minute, this is her 8th visit to the battered spouse shelter. Every time she comes, it is actually in fact true that she doesn't deserve that abuse, the kids don't deserve it, he's the perp, she's out of there, she's done. We give thumbs up, we give affirmations, and she goes back. Why? What happens? She gets on this slippery slope, and she ends up back at, of course, the most sensible thing I could possibly do right now would be go back and live with my perpetrator. So she's now in the I'm okay, you're okay, everything's okay, all the bad stuff's over there, and we're back with the husband again, and everything's great for a week or a month or 2 months. Kapow, we're back at the battered spouse shelter. So the problem of attachment to the perpetrator and these two split channels of thinking, seeing, feeling, behaving, planning, decision-making are not just a theory. They're right in your face, observable in her behavior. And her tone, her manner, her energy about when she's talking about the subject of the husband, completely different from when she walks in to when she walks out to go back home. So this is the problem of attachment to the perpetrator. And the person who has the official borderline personality disorder has it big time. Hold on a sec, hold the thought. Another woman comes into the program, and her MRI looks exactly the same, because the same thing's going on inside her brain. But her clinical presentation is very dramatically different. She's all, oh, Dr. Ross, you know, things aren't as bad as they used to be. I mean, this woman's 35. I don't mind living in the trailer park with Mom. She's older now, and, you know, she's not as well as she used to be, and Dad hasn't come over drunk and beat Mom up for at least 3 months now. And by the way, thank you, Dr. Ross, for letting me come to your wonderful program. You're a fabulous therapist. I think you're much better than my previous 26 therapists. So this woman is like the beaten down doormat of the world. She's enmeshed and codependent. She doesn't have a negative word to say about anybody or anything. She's all in the positive to avoid the pain of the negative. So she's just in I'm okay, you're okay mode. Although she's 35 years old, she's on disability, she's never had a primary love relationship, she's got no career, and she's been the primary caretaker for her hypochondriacal mom since she was 6 years old. So what's my treatment plan for this woman? I want her to be more borderline. She's not borderline enough. I'd like to hear a little bit of, I'm mad as hell and I'm not going to take it anymore. This is ridiculous. Look at this guy. He's never been to an AA meeting. She's the world's leading hypochondriac. I'm writing the Guinness Book of World Records right now. She should be in it. That's their dance. I'm done with all this. I'm getting a life, and that's it. Wait a minute. No life skills? No other support systems? No self-confidence? No self-esteem? I'm really just operating out of a wounded, dependent, small child. Sorry, Dr. Ross, I didn't mean to say those cruel things about my mother and my father. I think I should go home now. Mom's a little bit older, needs to be taken care of. So these two women have very different clinical presentations. One gets to be dependent personality disorder, the other one's a bad borderline. But underneath it's exactly the same problem. They're just solving it in different fashions. One hides in the positive, one hides in the negative, or actually the borderline bounces back and forth from one to the other. And if you get tired of that mess, you can always get stoned, wasted, or act out in some other way. So the problem of the attachment to the perpetrator underlies all of this mess. And when you slow the freight train down enough, you get off at the station, you take a look at the situation, you realize that neither half of reality is the whole picture. You start to get it cognitively. And what is it that sinks in? I loved the people who hurt me. I was hurt by the people that I loved. Both things were true. I felt both sets of feelings. It was intolerably painful conflict. And for my survival, I had to put the bad stuff out of there and have some kind of bonding and attachment. Because it's better to be a bad little girl with good parents than a good girl with bad parents. That's too scary. You can't afford to see reality. So that's the problem of attachment to the perpetrator. And when you get that, then you don't just tiptoe off through the tulips and everything's okay.